Dr. Bob Dannenhoffer, the Public Health Officer of Douglas County, Oregon. Today with another of our Facebook Lives. It's Tuesday, November 24th. We've been doing this now for 8 full months, and we've got a lot of stuff tonight. So I'm in the room all by myself, so I can take my mask down, thank goodness, and we'll go ahead and do this. So always, this is a chance for you to ask questions. We've already had a number of questions on Facebook Live, so we will go ahead and answer those first, but put your questions in the comment section and we'll get to them. As we always do, we start off at the world level and then move down, and it is pretty grim. There are 60 million cases worldwide, 1.4 million deaths. We're having 600,000 new cases per day and about 10,000 deaths a day. So lots of cases, lots of deaths, and overall a tremendous impact on the world. In the world, the U.S. is the most active place, and we're having a steeply rising number of cases. India, Italy, Brazil, Russia, Poland, UK, and France also make up the top 7, but we in the United States have about as much disease as all those next 7 countries together. And in India, Italy, Brazil, Poland, UK, and France, it's going down. The only 2 big countries where the rate is really going up are US and Russia, and then also in Sweden, which is a smaller country. And we'll get to Sweden later. In the U.S., we're 12.9 million cases and 265,000 deaths. We're now averaging 175,000 cases a day. Just a stunning number. And we're averaging more than 1,500 deaths a day. When you think of that, that's more than 1 death every minute. It's really active throughout the country. 37 states have over 1,000 cases in a day, including Oregon. And in Oregon, we're at 65,000 cases and over 820 deaths. You know, over the last week, we've seen every day another high, another high, another high, a little lower now, but still a tremendously high amount. And hospitalizations are very high, over 400 hospitalizations in the state. And while we're still not totally strained yet, I was on a call this morning with a group of hospitals from the Portland area, and they were down to a time this weekend where there were only 4 ICU beds in all of Portland. That is really scary, right? Because big car wreck, something else happened, you could use those beds up in an instant. And remember, gatherings are followed by cases, which are followed by hospitalizations and death, and we're still seeing this huge rise in cases. That the worry is that we're going to see this huge rise in hospitalizations and huge rise in deaths coming in the next few weeks. So really, really worried about that. Douglas County, we've done no better. We had 36 new cases today, 858 total. We have 17 deaths, 2 more this week. And in this whole week, between 15 and 20 being hospitalized. That's a lot of people in the hospital. Remember, our ICU in the hospital only has 16 beds. Now, all of these people are not in the ICU. Typically, about a third of the people in the ICU, a third of the people in the PCU, and a third of the people on the medical floor. But this really impacts the hospital. I mean, hospitals are usually pretty full even without COVID, but now you add this number of patients and it's really a worry. And it's really a worry because many of our cases now are really older people. And older people are the ones who tend to be in the hospital and get really sick with it. You know, we went for months without any super spreader events. And with no super spreader events, we were really able to keep it low. But over the last week or 2, we've been dealing with 3 separate, maybe 4 separate super spreader events. And this has really knocked things totally out of control. So in the Reedsport area, they had almost no disease in September and October, maybe an occasional onesie, twosie case. They then had a big Halloween party. About 28 people from that party got sick. Now there's over 40 people in the Reedsport area with the disease. We can't exactly figure out how they're all connected anymore because there are just so many cases. And it's really overwhelming, that small town. You know, it's in so many businesses. It's in the school, it's in the hospital, it's in the clinic, it's at the harbor. It's really, really devastating that community. We have one at Curry Manor. There's over 30 cases, mostly older people, some really, really sick people. And then there's a church event where there's another one where there's over 20 cases. Now, in that one, there's 5 hospitalizations. I mean, 5 hospitalizations and a death. So there's really a lot of disease associated with these super spreader events. And every one of these super spreader events were started by something that could have been avoided. And we're not saying could have been avoided by somebody doing something superhuman. It is not going to work when you're sick and avoiding these big gatherings. So it really is very, 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 very worrisome. Anyway, let me get to questions. I've got a lot of other neat new stuff coming out today. So if we get a time, we'll get there. If not, we'll get it the next time. So Mark, a guy I went to RPI with, says a vaccine is expected to confer 1 or 2 years of immunity. Why are people who've had the actual disease say that they only may be immune for 3 months? Why would a vaccine be more effective than actually contracting the disease? So the answer is that doesn't seem right. It seems if you get the disease and are sick with the disease, you'd have a much higher antibody level than if you just happen to get a vaccine. But that's not always the way it is. So, for example, there are a number of diseases out there that you don't get particularly good immunity from the disease, but you get great immunity from the vaccine. The most common of those, and the most notable of these, is one called Haemophilus influenza B. So Haemophilus influenza B is a terrible bacterial disease that can cause meningitis and pneumonia and joint infections and skin infections, really one of the really worst issues in childhood. When I started being a pediatrician, we've since developed a vaccine, and there's been no cases of Hib disease anywhere in Oregon in the last 10 years because the vaccine is so effective. The vaccine is so much more effective than getting the disease, and it appears to be also the case with this one. Now, it may be because this vaccine, especially the Pfizer vaccine and the Mrna vaccine, produce a large amount of the spike protein. And so you get a really good antibody response to the spike protein, and that actually may be more effective than actually contracting the disease where you're faced with lots of antigens. We don't exactly know, but it's not unheard of that this would happen. So then if multiple vaccines become available, would it be a benefit to get one vaccine for the first shot and then a different one for the booster shot? Perhaps, but I think all of the trials have been done with a booster of the same vaccine you got the first time. So I think could be, but I think the recommendation would be to get a booster with the same vaccine you got the first time. So E. Dennison asks, what is the cycle threshold being used in Douglas County for the PCR tests? This is a bit of a nerdy question, but the way PCR works is that you get a virus, and then you get the nucleic acids from there, and then you multiply those, and then you multiply them by cycles. It's not exactly double, but let's believe it's sort of doubled. And so you start with 1, and then 2, and then 4, then 8, then 16. And by the time you get out to 30 cycles, you got a lot of viruses there, or a lot of material. And then what you do is you read that material at different cycles. As you go more and more cycles to detect the disease, it means there was less virus to start. So when people are really contagious, you find the disease in 5 or 8 cycles. When people are mildly contagious, you find it in 10 or 20. And when you only find it in 30 to 40 cycles, that people do not have that much disease and may not be that contagious. We don't do the test here in Douglas County. We send it out to Quest. Quest uses less than 40 cycles, so 39 point something cycles to find it. You can look at the cycle amount, and we do sometimes, to see kind of what the viral load is on this. In Oregon, a positive is a positive, so it doesn't really make that much difference. So yeah, 40 is the cycle time. So someone said, I recently had a conversation with a resident of Douglas County, and they said that somebody was theorizing that coronavirus was a man-made virus sent upon us by China to discredit the president. Well, this is one of the theories that's clearly out there, is that this is a man-made virus made in China. I think the people who actually do virology say that this is not really believable. You can find that it was in bats and maybe in pangolins before it got to people. And while we're good at manipulating viruses and stuff, we're not that good. And nobody thinks that nobody that I know of thinks this was a man-made virus. Doesn't change much of what I would do, though. What I would do would be still to try and keep it down. So Carol says, my husband had a very mild case of coronavirus as in a high-risk group. Should he be tested for antibodies or still consider getting a vaccine? We do not know if you've had the disease, whether you're going to be on the list to get the the vaccine, or if you were in the trial in the placebo group, whether you should get a vaccine. And so those are things that we should find out in the next 2 weeks as these vaccines get approved. So are the targets for outcomes of the pending vaccines underway aimed at blocking the infection from occurring, or rather to reduce to mild or moderate symptoms? They're actually looking for both. So they're looking to see when people get the disease, how sick are they, and whether they get sick at all. And so it seems that this vaccine not only decreases your risk of getting it by over 90%, but when you look at the severe disease, most of the severe diseases in the placebo group, so it does appear that it does both, blocks you from getting the infection and decreases the severity if you get it. That would be the very best outcome. And then someone says, after being exposed to a positive, why are some people allowed to go back to work? I'm confused by this. Yeah, it is confusing, Linda asks. So here's the story. So the story is, if you're exposed to the disease, you're supposed to quarantine for 2 weeks. So I'm a contact, somebody in my household or whatever, I'm supposed to stay home for 2 weeks. That is far and away the safest thing to do. The concern, however, early on was that if you made everybody who was in the hospital who was exposed to a case stay home for 2 weeks, after a week or two, there'd be nobody left in the hospital and you couldn't do it. So there are 3 separate groups of rules. So the group for healthcare workers, if you are a contact during your work in the hospital, they assume that you're wearing appropriate PPE, and that doesn't count as a contact. So you could imagine if you worked in the hospital in an ICU where there were 5 people with COVID, if you were wearing appropriate PPE, your contact with those 5 people would not be considered a contact. The second is if a healthcare worker if a healthcare worker is a contact not at the hospital but a contact at home, your wife has it, your friend has it, somebody else has it, and you were exposed to them. Healthcare workers are allowed to work through quarantine. So even though they're supposed to quarantine, they're allowed to go to work during the day while they quarantine, with the assumption that they will use high-quality PPE, they know how to use the high-quality PPE, and that they won't spread it to others. So that's an exception. The third exception is for people who work in essential businesses, and many businesses are essential. Schools, banks, power, wood products, waste management, all of those are considered to be essential workers. So there's a lot of essential workers. So if you're a contact who's an essential worker, you can work it out with the health officer that if you follow all the rules, you can go to work. So there was a work site where the people in the mechanic shop were exposed. This was a business. It was a wood products business. You know, they're right now taking a lot of these down trees, and they really needed to continue to work. But if we followed the typical rules, all 5 of the guys in the shop would be out. And if the 5 guys who worked in the repair shop were out, it wouldn't take very long before this wood products firm would totally need to close down because things break. And so we made a deal with them that these guys could work, but they needed to work separately. They couldn't expose others. They needed to go right to their repair bay. If there was something that needed 2 people to do it, they wouldn't do it. You get other unexposed people do it. So we do everything to make it safe so they won't spread it to others, and then they're allowed to work through quarantine. Some counties don't let people work through quarantine. We have been very lenient with that. I don't think we've turned one down yet, if they can show that they're going to be very safe. And so and that's why it's confusing. So it could be, in the one case, somebody was a contact, they were asked to quarantine for 2 weeks. Somebody was a contact, they were allowed to work because they were essential worker. Or somebody was a contact, they were a healthcare worker, and they were allowed to work through quarantine. And it is confusing, but that's the way it is. So if there are follow-up questions from that, let me know. All right, let me go to my next stuff here. Okay, so some very interesting. So there was a question last time about this nose spray. This is a nose spray that could protect it. I looked up more on this. This is a lipopeptide. So a peptide meaning a short piece of a protein covered in lipids. And the thought is that it would get in your nose and block the ACE2 receptors. So when the virus got in your nose, you may not be able to get infected. They've tried it out in ferrets, these little mink-like animals. They've tried it out in ferrets and seemed to work, but it's pretty far off from human stuff. Okay. Yeah, so Heidi said, I keep getting told that people who have died had underlying conditions and didn't die from COVID, and that COVID is less serious. What would good answer to that be? Heidi asks. Okay, so let me tell you the story on this. Is that as we get older, we frequently have underlying conditions. So if you look at people 60 and above, about 85% of people 60 and above have one underlying condition or more, right? So high blood pressure, obesity, something else, maybe a smoker or something else. CDC did a survey, and they looked at the death certificates, and they said on the death certificates people had an average of 2.6 underlying conditions, which actually was not the least bit surprising. Well, somehow somebody spun that to mean that these people didn't actually die of COVID, they died of the other things. I mean, I have a crisp $50 bill for the first person who can show me a death in Oregon, because I can check those out, a death in Oregon that was said to be COVID, that after review you'd say, well, that wasn't really COVID. I mean, it could happen that you got tested for COVID, you were positive, and then got run over by a train. It could happen. I've yet to see one. I mean, these 800 deaths in Oregon follow this very typical course. There are people, usually older people, but not always, who get this, who get sick, who get respiratory distress. They go to the hospital. They have acute adult respiratory distress syndrome, or ARDS. They're really, really sick. They're isolated from their peers. They're either breathing really hard and they're awake, or they get put out and get intubated, and they die a terrible death on the ventilator. In that case, the right way to write the death certificate would be this person died of ARDS secondary to COVID. Now, if they also had obesity, hypertension, something else along the way, those would be appropriate to put on the death certificate. It's complicated by obesity, complicated by chronic renal failure, something else. Those would all be appropriate. And so the story is, that's how it is. That's how it is with every disease. And there really aren't people, this story of the people with COVID getting run over by a bus, yeah, theoretically possible, but you find me a case and I'll give you $50. I've been promising this for 4 months now, and nobody's taken me up on it. And so when there's a crisp $50 bill for somebody who can show me that, and nobody can show me that, it would suggest it doesn't exist. The point is that we know about these cases. We see these cases. I see the medical records. These are people who get really, really, really sick, and they die a miserable death. COVID is real. I mean, I was back in the hospital during the 2009 stuff. We'd have a few people in the hospital, a couple of deaths. We are now having 15 or 20 in the hospital at any one time. These people are really, really, really sick. This is not like the flu. Please, let's get past this. I mean, really, if anybody logical can carry on a discussion about that, I'd love to have it, because COVID is real. COVID is really serious. Those people are dying of COVID. It's not like they're dying of dementia. By the way, they happen to have COVID. At least all the deaths we've had, these have been terribly sick people who've died miserable deaths. Robin says, are the ones hospitalized all at Mercy? They're not all at Mercy. I think we have one now at Sacred Heart and one at one of the VA. But for overall, most of these are hospitalized at Mercy. So when it says DPHN is supporting cases in quarantine and isolation, what does that mean? Joanne asks. So we're trying to help people stay in quarantine. So sometimes we provide people thermometers or pulse oxes. So this weekend I went to Reedsport and made 5 deliveries of those to people all throughout the Reedsport area, so they could have thermometers, or that we help them with notes for work. We help them get signed up for COVID pay. Sometimes we deliver medicines or groceries. In some cases, we've even delivered stuff like dog food and whatever to help people stay in quarantine. And that's what we mean with support through quarantine. Now, we obviously can't do it for everything for everybody. So this is where friends, church organizations, and others come in. So Casey says, I worry about the homeless. Do we know how the pandemic is impacting the homeless population? So throughout the country, this has had a big impact in homeless populations who live in large shelters. So if you go to some of these big cities, they have really large shelters, hundreds of people in the shelters, and it really spreads quickly through those shelters. Thank goodness in Douglas County, we do not have those large shelters. Many of our homeless live outside, which is problematic, but from COVID point of view, it actually decreases their chance of getting it, since outdoor transmission is maybe 10 or 100 times less than indoor transmission, and because there's not a lot of gathering, inside gathering among our homeless population, we really have not seen very many cases among the homeless population. One of the things we're trying to do is to avoid that gathering or that crowding, because we do know that it could spread quickly. So Maddie says, is there somewhere local have the antibody testing done? Anywhere. Basically, any of the labs do that testing. Again, I would go with one of the bigger, more reputable labs, Butt Lab, CoreQuest, Mercy, Mayo Clinic, any of those places can do it. Yeah, so Lori says, when the vaccine is ready, how will distribution work? I have asthma. Should I assume my doctor will know I am in the third or fourth risk group? So let's put all the vaccine questions together. So Corey says, will the Northwest vaccine panel delay us getting the vaccine? And Michelle says, do all the vaccines appear to be equally effective against all age groups? And so that's great. So let's go ahead with the vaccine. So vaccine news this week, the Mrna and the Pfizer vaccine are both scheduled they both submitted emergency use applications. They're going to be reviewed by the FDA and then by a group called the ACIP, which makes recommendations on who should get it and when. So we're expecting that by maybe the 20th or so of December that we will get approvals, and then we'll get shipments thereafter. We think the way this is going to work, and again, this is not totally spelled out yet, we think that initially this vaccine will be distributed one group to the hospital, because it needs to be stored at incredibly cold temperatures that you really can't do outside the hospital, and then the rest will go to public health. It then goes in groups. The first group is healthcare workers that have direct contact with patients. That's really a high-risk group, and that's the group should get it. So we think, for example, if we could immunize all the nursing home workers and get them all immune, we could really stop nursing home outbreaks, really a dangerous thing, because almost always the disease comes in through workers. You know, a bunch of workers, one of them gets sick at a party or something else, they bring it to the nursing home, and then everybody gets sick. So the first group is going to be people with direct contact with high-risk patients. And so that would be nursing home workers, doctors, nurses, whatever, that have contact with high-risk patients. The second is going to be other people in healthcare, and then the third is, and then it goes down the list of what those are. Oregon has not exactly put out what the list is yet, but you'll be in those groups. We will have a way to communicate to people what group they're in and when they would be expected to get the vaccine. My best view is that we'll get the healthcare workers done between December and the end of January. And then starting in February, we'll be doing second vaccines for the healthcare workers and starting on some of those higher risk groups. And especially the highest risk groups are going to be older people with underlying conditions. So that's what the hope is. So the hope is that these vaccines get approved in December, that they start arriving at the end of December, that we start immunizing the highest risk workers in December. In January and February, we start immunizing everybody else, because the vaccine has to be done in very specific circumstances. Right? This is not a vaccine that you can just leave just put it in your little refrigerator. It's got to be stored at incredibly cold temperatures that we're probably not going to have this everywhere, at least to start. Now, the new thing that came out is the AstraZeneca vaccine, and this AstraZeneca vaccine actually does not have as difficult storage requirements. It had a little funny data around it. It's probably not ready for an EUA for another month or so. So we'll see a little bit what's happening with the AstraZeneca vaccine. And then what's going to happen is it's going to have, for Oregon, 3 levels of review. So the first is going to be the FDA panel. The second is going to be the ACIP panel. And they do different things. So the FDA panel looks at one group of factors. The ACIP panel looks at a second group of factors, and then this Northwest vaccine panel will look at it. We do not expect that this will delay anything. The concern was, when this was put together, was that there was so much politicking going on and that there might be data hidden in whatever. Well, I think in the last 2 weeks, it's become pretty clear that that won't happen. And so the data will be free there. And I don't think the vaccine panel is going to delay us getting the vaccine at all. Michelle says that the new vaccine appear to be equally effective in all groups. With the vaccines that they've released the age stratifications on, it does. I did not see the age stratifications on the AstraZeneca vaccine, so I do not know. Yuka asks, how come the number of test positivity has been changed? This is a complicated question, but let me answer it for you. So test positivity just overall means like what percentage of the tests you're doing are positive. And that's an important thing to know because it gives you a sense of how well you have this under control. We know that if your test positivity is 50%, there's disease everywhere. If your positivity is less than 1%, you have this pretty much under control. And actually, for the nerds among us, this is my number one thing to follow. I can look at your test positivity rate and tell you what's going on. So you could tell in North Dakota and South Dakota when their test positivity rate, which had been in the single digits, went to the 20s and 30s, you knew that 2 weeks later they would just have an amazing explosion. Similarly, in Oregon, as it went up, you knew that we were going to have an increase in cases. Not an explosion yet, but clearly an increase. So there are a couple of different ways to compute test positivity. That is where we've not had good leadership from the CDC saying use this method. They basically said any of the approved methods was okay. So we use the method that we typically use in outbreaks like Salmonella outbreak or a norovirus outbreak. So let's take a Salmonella outbreak. So there is an outbreak, say, of Salmonella in a certain food group. And then what you do is you test people and you say that, of the 100 people who had bloody diarrhea, 50% of them had the Salmonella type. You know that there's a lot of Salmonella out there. But if it gets down to 2 or 3%, you know you're kind of moving this out of the population. So we used in Oregon, we used in the beginning called the person method. So you were looking for newly positive people. So people who were either not tested before or people who were tested previously negative now turned positive over the total number of newly negative and newly positive people. So newly positive over newly negative plus newly positive. And early on, this number tracked pretty well by using all the different methods. Well, what happens after a while, there are some people who are getting tested multiple times. So like if you work at a nursing home or another high-risk area where you get tested multiple times, your negative test once you were negative, you could not be a newly negative, right? Because if you were negative in April and then you got tested again in July, you wouldn't be a newly negative person. Only somebody who had never been tested before would be considered newly negative. So what started happening a little bit in the summer and really in October and November was that the rate using the different methodologies really changed. And so Oregon decided a few weeks ago that we would switch from the person method to the test method. There are technical advantages to each, but since most states now are using the test method, and because this has dragged on so long, Oregon also then moved to the test method. What that did is that in many places decreased the rate of positivity. So it decreased the rate of positivity in Douglas County from about 9% to 6%. In some places it decreased it more, especially if you've done a lot of testing previously. So for the math nerds out there, if you tested everybody in a community, let's say you went out and tested everybody in July, 100% of the Douglas County people, every week the calculation would be the person who was previously negative and now became positive would be in the numerator, and the denominator would only be the newly positive. So you'd always have a positivity rate of 100%. Well, that never happened because there's no place in Oregon that did that. But you could see that with time that the test rate and the person rate would really start to diverge, and that's why Oregon did it. I think this is perfectly reasonable, and so we've switched. I think we're going to stay with this rate, and this then is going to make us much more comparable to the other states that have already moved to the test positivity method. So Chip says, if somebody who has been tested positive gets retested and is still positive, does that count as 2 cases? No, cases are still counted by the person, so it still counts as 1 person. The only difference is if you were positive in March, go and are well, go 90 days and then get positive again, it is counted as 2 cases, but we've not had very few of those. We do have 1 of those in the county. Somebody who was a rescue worker, an aid worker, back during the big time, worked back east, was positive. They got better, and now it's positive again. And we think it's a new case, but we don't know. So Carlos says, do you think there'll be mental health funding available to the public who are overly stressed? I certainly hope so. There's a lot of stress out there. I mean, there's stress about kids not being at school. There's stress at businesses that may be closed. There's stress from families that are dealing with loved ones who are sick and loved ones who are in the hospital and loved ones who die. There's a lot of that. I do not know what's going to happen with any of the funding. So the funding to get us through this was called CARES Act funding. And this CARES Act funding ends December 30th, not the 31st. It ends December the 30th. And we don't really know what the funding is going to be after that. I mean, very clearly, we're not going to be done with this by December the 30th. And so we are going to need some funding, and I would hope that that funding includes mental health funding. So Bruce says, why are we closing outdoor restaurant service if that's not a likely source of infection? Yeah, so this was a parsing along the way. You have to do it at some point. I think when the new guidelines come out, I think tomorrow, you'll see that those are differentiated between indoor and outdoor service. So Ralph says, are hospitalized COVID patients being managed by their primary care docs or by a smaller group of physicians with special training? So the answer is sometimes the primary care docs are involved, but in most of our COVID patients, they're being treated by a small group of doctors called hospitalists who are specially trained in inpatient medicine and are really quite up to date with what's going on with COVID. And then for people who get sicker and need respiratory support, they're also being managed by the intensivists. So Wendy says, when you say 40 sick with COVID in Reedsport, does that mean all cases are just mildly sick or all really sick? Well, like with this disease, it runs the gamut. Death, hospitalizations, pretty sick, to people who are mildly sick. I don't think we have any asymptomatic people. Somebody can check on that. I actually went to Reedsport this weekend to deliver thermometers and pulse oxes and whatever, and I went to 5 different households, and they range from one family that really looked pretty miserable to one guy who looked pretty healthy. So I think it is just all over like we see. So when we look at the range of people who have COVID, maybe 20% are asymptomatic or very mildly symptomatic. Another 20 to 40% are mildly symptomatic, and I talked to a bunch of people like that. About 10% of the people are pretty sick. They wind up in the emergency room, may wind up hospitalized for a day or two, and then 10% are really, really sick, and they wind up in the hospital really critically ill. And that's sort of what we've seen in each of these populations. So one of the church groups that we've had here, there's about 25 in the group, they've had 5 hospitalizations, more than you would have expected, and 1 death. So they've been sicker than the average crowd. And then there are other groups where people are a little less sick. But when so I do these case investigations. I call people on the phone and see how they're feeling. And, some people are not that sick. I talked to a family today, a young, healthy guy. And for him, it was like a flu-like illness. He felt really achy one day, really tired one day, had some cough and change in his sense of taste. He thought everything tasted like mold. But he wasn't really very sick. But then I talked to another person on Saturday night who was really quite sick. She'd just gotten back from the hospital, and then the next day got admitted again. So it runs the gamut. And in Reedsport, it just runs the gamut. So Heather says, what are my recommendations on flu shots? Get one. Anytime. So flu has been very mild this year. We have seen only one local case, so there's not very much flu, but let's keep it that way. So Karen said, I saw in the news that the vaccine has bad side effects. Is this true? So there are, again, there's lots of different vaccines, but there's 4 that are close to being done. So the Mrna vaccine and the Pfizer vaccine are this mRNA vaccines. There have been no safety signals on those. So safety signals means something that happens that's funny. Like you're a young person who had a stroke, or you're a young person who had a transverse myelitis, or a young person who had a heart attack unexpectedly. Those little safety signals that would make you think, there's something going on there. They did not have any safety signals on the Pfizer or the Moderna vaccine. And that's what the FDA and the ACIP and the vaccine panel will look for. Is that really true that there were no safety signals? So I think those are going to be safe. Now, the concern with the mRNA vaccines is the mRNA vaccines are new. So there's no vaccines out there now that are mRNA vaccines. And what you do is you take a little piece of genetic material, coat it in a lipid, which is a fat, and then inject it into the bloodstream. Well, cells see fat and they say, oh, time to eat it. And like Miss Pac-Man, they gobble it up. And when they gobble it up, they then get this mRNA in the cell, and this mRNA in the cell then causes the cell to make the spike protein. The spike protein says, well, I don't need that, and expels it. It gets in the bloodstream. The bloodstream says, oh, that's not a protein that's supposed to be here, and it makes an immune response. So we've never had an mRNA vaccine, so people are worried. When you look at it, though, I think there's nothing about the mRNA vaccines that really worries me. The AstraZeneca vaccine and the Johnson & Johnson vaccines are adenovirus vaccines. The AstraZeneca is a chimpanzee adenovirus. The J&J is an human adenovirus. Now, both of them have had some safety signals. And so those are going to really get carefully looked at on those safety signals to see if there's anything going on here. So Amy says, if you've already had COVID, will it be necessary to get the vaccine? I don't know. And that's one of the things that the ACIP needs to come up with at the end of December when they meet. So Linda says, will people be able to choose which vaccine they get? I don't know. And again, that's one of the things that we'll find out from ACIP. So Penny says, does the vaccine contain a weakened live virus? Is it possible to get the virus from the vaccine? So the mRNA vaccine does not contain a weakened live virus. The AstraZeneca and the J&J do. And is it possible to get the virus from the vaccine? Well, I think, yes, you do get the virus from the vaccine, and that's how it works. And that's why, because we're actually giving you a weakened live virus, that's why we worry a little bit more about the AstraZeneca and the J&J. So under new guidelines, will it allow the closed business to reopen soon? So you have to wait till tomorrow. You have to wait till tomorrow to see. I think is a very reasonable plan to allow places to open, but it depends upon bringing the number of cases down. So we've got to bring the number of cases down. So when I look at our number of cases is well over 200 per 100,000, which puts us in the highest risk group. We need to bring it back to like we were in September, October, where we're having 5 or 10 new cases a day. We can't continue to have 30 new cases a day. Because this is just spread. So we really need to bring it down. So the question is, who's issuing the new guidance? Is it OHA or the governor? It's always the governor. OHA does have some input. Okay, a couple of you write in some more questions here, and we'll go through some other things. One is this fascinating thing called nanobodies. So most animals have antibodies, which are fairly big, complicated things. They look like a big Y. They've got a bunch of proteins all together to make antibodies work. For whatever reason, camels and llamas, they have the regular kind of antibodies, but in addition, they have these tiny little antibodies, which seem to be really effective, called nanobodies. And so the thought is, rather than getting these really complicated antibodies like Eli Lilly and Regeneron are making, maybe you could use camel nanobodies that would be much, much, much more easy to do. And so there's some good work on it. So when you hear about llama nanobodies, you'll say, "Oh, I've heard about that." You'll seem like a genius. A study came out just today looking at the seroprevalence. looking at blood samples on people, using antibody tests to see what the level of antibodies is in different places. And this goes along with data that we've seen before, that places that were really hard hit, like Brooklyn, it's about the 20% of the people have already had the disease. But if you look in places where not that many people have the disease, like in Oregon, only 2 or 3% have seroprevalence, which means that there's 97 or 98% of the rest of us who could get this disease. The other thing that we've seen is, you'll remember we've talked over the time about Sweden that took sort of a different approach. So Sweden took an approach that had much less restrictions, and the thought is that they might build up herd immunity and they'd be able to get through the second wave with much less disease. Sorry, it didn't work out that way. So what happens now is Sweden has had a lot of disease and a lot more deaths than its neighbors, and is now imposing restrictions like many of the other places. So their experiment in herd immunity didn't work, but over the time, it cost them about 5,000 more deaths than their neighbors. So we'll see. New thing that came out today about a drug called Luvox, or fluvoxamine. So Luvox is a drug we've been using for a long time, and it usually use it to treat obsessive compulsive disorders. Early on in this, it was recognized that fluvoxamine interacts with the sigma-1 receptor, and that interaction with the sigma-1 receptor could make a difference with COVID. And they did some retrospective stuff that looked to see that people who got antidepressants that also work on S1 receptor seem to have less disease. So they did a double-blind control study, and it's fascinating because they never actually even saw the patient. What they did is, when people got positive test results, they received a little bag, and the little bag had a thermometer and a pulse ox and information on what to do. And it said, if you want to be in this study, take the pills that are in it. Some of the pills had Luvox, some of the baskets had placebo, and then they checked, and it turned out that the people who got the Luvox had much less progression of respiratory disease. That's fascinating. And so that was a study of about 70 on each side, so a reasonably sized study. And so they're going to do a bigger controlled study. But fluvoxamine would be a great thing. You know, if you could take 2 weeks of fluvoxamine and it decreased your risk of getting respiratory complications, that would be great. One of the other things that came out this week is about older people who have delirium and failure to thrive as the only symptom, the only early symptom of COVID. So we usually think of the early symptom of COVID of being fever or chills or cough or loss of sense of smell or taste. But in a number of seniors, what they found was they came into the emergency room kind of out of it. Not really sick in any way, not feverish, but kind of out of it, and sometimes not wanting to eat. And then a few days later, it was clear they had COVID. So the recommendation now is, if you show up in the ED with delirium, they'll check for a lot of things. Do you have a brain bleed? Do you have a UTI? Do you have other kinds of things that would give you delirium? But what they'll also check now is, do you have COVID? Because COVID can do that. All right, so let's see what else we have here. So Heather says, are quarantine camps real? I haven't heard. I cannot see in Oregon how quarantine camps would work. I mean, I just have no sense. The best place to quarantine is at home in your own bedroom. So quarantine camps would be just a mess. So Brenda says, is contact tracing coming to an end? Well, contact tracing is really effective when you have a very few cases. You find a case, you find where they got it from and who they might have gotten it to, and then you surround those people with quarantine and you keep the case there. So back in the summertime and in the early fall, where we didn't have very many cases, boy, we were all over it like white on rice. And we were able to really contain those outbreaks. Unfortunately, what's happening now is, when people have cases and you say, where'd you get it from? They have like 2 or 3 different places they could have gotten it from, and their contacts have multiple people that they may have gotten it from. So it's so much harder to do contact tracing when you have so many more cases. So as you double the number of cases, it's not just twice as hard, it's 4 times as hard. And since we have about 6 times as many cases we had we had before. It's at least 10 or 20 times as hard to do contact tracing as it was before. So if we're going to really get this done through contact tracing, we really just need to get the case rate down. And then when we get the case rate down, we can track down these cases and see. So we're now working under surge guidelines. And the surge guidelines, rather than calling people every day for contact tracing, we're calling low-risk contacts at the beginning and the end. We're still calling high-risk contacts each day, but we're calling the low-risk contacts less frequently. And we're not always able to get to everyone on the same day. So when there's 36 cases in a day, 36 case investigation is a lot of time. So if you've ever done a case investigation or been part of it, there's like 50 questions to answer, and the 50 questions are all complicated questions. Where did you get this? Do you have these diseases? When did this start? And all those kind of things. And so I did a bunch this weekend. It takes a long time to do those. And so with 36 cases in a day, people are working late into the night to get them done, but we're not always able, as we were in the summer and the early fall, to get to people usually within an hour or two and get all the contacts that night. It's now sometimes taking us a day or two to get there. So what we need to do is just bring it down. And how will we bring the case rate down? It's really very easy. This disease has a typical incubation period of 5 or 6 days. So it doesn't take very many periods of 5 or 6 days if we stay at home, limit our contacts, don't expose ourselves to others, to bring this right down. So if I look in this month, which has really been a terrible month with the number of cases that we've had, it's been volitional decisions that, in retrospect, really, really caused a lot of troubles. Having a big Halloween party with a bunch of older people, having a harvest party with a bunch of older people, going to work while you were sick in a nursing home, all things that really, really spread the disease. And had people not done them, presumably we wouldn't have had those 100 cases that related to. So it won't take long to bring it down if people will follow the rules. And that's why for Thanksgiving we're incredibly cautious about what happens. So we think that in a typical year in Douglas County, that there would likely be 5,000 gatherings of people for Thanksgiving. And ours would have been one of them. So every year for Thanksgiving, we do something with my wife's family. And so we typically have, 10 or 20 people there gathering in one of our houses, somewhere up and down, and we eat and drink and have pies and watch football and do all those things. The concern is going to be that if there were 5,000 of those, we don't expect all of those people to have an outcome. But if even 100 of them did, and there were 6 cases in each one, which is about what you'd expect, that would be 600 cases coming in the week after Thanksgiving. 600. We usually, we had 36. I told you we're kind of overwhelmed. Could you imagine next Wednesday getting the list that there are 600 cases in Douglas County? And that could easily happen if people do it. That's assuming that only 100 of these gatherings would have it. Only 100 out of 5,000. Only 1 in 50 would have an outbreak. So that would still mean 49 in 50 would be fine. But 1 in 50 and only 4 cases. Now that's sort of the best case scenario, right? It could be as high as 3 in 50 or 4 in 50, and it could be as many as 10 or 20. So we could have like 800 cases in Douglas County in one day, in which case it would be kind of over. So Linda says, what about the sewer testing in Douglas County? So the sewer testing it's very interesting that this virus does affect the GI system. So some people have nausea, abdominal pain, or diarrhea. And we do know that you can find the mRNA, although not necessarily the virus, in the poo of people, and mRNA is pretty stable. So what happens is now if somebody's got it in their poo, it gets in the water, and then you can measure how much mRNA is in the effluent from the sewage system to get you sort of an idea of how much disease there is in the community. This works especially well in an area where it's never had disease, and you use it to see if it shows up. So you can imagine, for example, the NBA bubbles, where presumably nobody's got the disease. You check the poo every day, and if you start to see a little bit of mRNA there, it means there's some infection in the bubble. We don't have any of those in Oregon. Second place to use it is if you have a lot of disease, like in a prison, and you're looking to see, is the rate of disease in the prison going down? And then you might sample weekly to see that that mRNA level was going down, to see that the amount was decreasing. And it may work in small, very small sewage systems where you could test, for example, maybe one dorm or one section of a campus to see how much disease there was there. Douglas County has not done the sewer testing because the sewage system in Douglas County is a large system. And since it's a relatively large system, it's not exactly clear what it would mean if there was positive mRNA in the Douglas County sewage system, because it does supply so many people. And so Douglas County was not one of the areas that has done it yet. We may at some point figure out a way to do it. So Christine says, well, what about blood types? Is there different susceptibility? Early on, there was a suggestion that there was, and I think there's a small difference in the different blood types. But since you can't change your blood type, probably doesn't make all that much difference. A couple of new things that came out. This, you've heard about this here, this D614 G mutation. And so this D614 G mutation was a mutation that happened relatively early on in April or May. And what it did was it changed the protein in the spike protein, so that the spike protein used to have sort of a weak area in it, which frequently would break off. And now it's got a much stronger spike protein that doesn't break off as much. And it seems to be much more likely to infect, although not much more serious should you get it. And when you look at the different areas in the world, what percentage had this mutation? Places had it earlier, like China and Italy, had low levels. You start getting places that were a little later, like France and England, they had more. And then if you look at places that had it later, like the U.S., we have a lot. And so this is one of the mutations. There are a lot of other mutations out there, but it seems like only the D614G is really important at this age. Doesn't mean that there won't be other important ones later on, but right now, it seems to be the important one. There was a thing from the British National Health Service, again, really misinterpreted, that looked at people who had COVID and said, well, where were you in the last week? And they found that the most likely place that people were was the supermarket, followed by daycare and educational things and whatever. And so NHS did that to see where people were, but they never suggested that people got this at the supermarket, right? Probably the most likely place they were was in their own bathroom, right? Almost everybody goes to their own bathroom once a day, but nobody is suggesting that's where they got it from. Well, people got onto this, that supermarkets were the place this was spreading. And as much as the National Health Service said, no, that's not what we meant, and that's never what we said, that's how it was taken up. So restaurants and bars were lower on the list, and restaurants and bars have used that as, well, why are we closed when people are much more likely to have visited supermarkets? Well, most of us might go to the supermarket every day, but I certainly don't go to a bar every day. And so this is another misinterpreted study. Masks. How could you get through a Facebook Live without talking about masks? 2 studies that came out in masks. One from Kansas that suggested that the counties that enforce mask mandates had a much slower rate of rise than places that did not enforce a mask mandate. They did a controlled study in Europe where they had some people where they just gave them advice. This was early on in the pandemic, gave them advice about what they should do and didn't include masks. Another group, the other group that was a randomized group, they said, this is what you should do. Plus, here are masks, you really should wear masks. And what they found is that the group that wore masks were a little less likely to get the disease than those who didn't wear masks. A couple of problems. There were some people in the control group that did wear masks, as well as there were a lot of people in the intervention group who were asked to wear a mask and didn't. And, again, we think masks probably help you a little bit, but What we really think is that they help prevent you from spreading to others, and there was no way for them to test that. So again, that has been misinterpreted as masks don't work. And the answer is no, read the study. And when I look at these, I always look at the study. The news reports are just the news reports. I look at the study, and what it showed was that masks are not super, at least in this study, didn't seem to be super effective in preventing me from getting it, but that it was almost exactly as I would have expected. Okay, more questions. I have two more things, and if we don't go, we'll be done here. So one of the deals is about what we recommend for this holiday weekend. So what we recommend for this holiday weekend is to celebrate and give thanks for the great things we have, and for those of us who've not yet had the disease, that we've not yet been affected by the COVID. I would strongly, strongly, strongly suggest that you celebrate Thanksgiving in person, only with your household. So my wife and I are going to have Thanksgiving. But, we've got kids all over the country, and we're going to do a little Zoom thing or a go-to-meeting thing where we're going to see them all and talk with them and chat with them and see how they're doing. And so we're going to go ahead and do that, and I would encourage you to do the same. I would encourage people to watch the Oregon and Oregon State, again, with your household rather than with a big crowd at the bar. And then we would also encourage people to get out, enjoy. The weather's supposed to be sort of okay, so get out, get some exercise. And we need to hold off a little bit on big family gatherings. People say, well, people may not be alive the next time I see them. Grandma's old and she may not be alive. But if she's that close to dying, the worst thing that could happen to her would be to get COVID. Because if she's old and sick, if she got COVID, she really could die. You say, well, what about getting a test before I go? And so that's sort of an American obsession with getting tests. But let me tell you the story here. Getting tests is not perfect. So we put together this little thing today. So let's say it is Monday or Sunday, and I get exposed. So Sunday, I have play poker with my friends. We don't wear masks, and I get exposed on Sunday. Think, well, I was just four of us. We were just sitting around playing poker, and one of the other people there is infectious, and I'm exposed on Sunday. I say, well, I want to go visit my elderly mother on day 3. So on day 3, which is Sunday, so Sunday's day 1, Monday, Tuesday. Tuesday, I said, I'm going to be really a smart guy. I'm going to go get a test. And when I get a test, I feel fine. I get the test comes back, and it is negative. It's a true negative. It comes back negative. I say, well, that will be great. That is really great because, other than playing poker with my friends, I really haven't been out very much. I got tested on Tuesday. It felt great. On Thursday, on day 5, I still feel great. And so I have dinner and in this little thing here, with 17 others. And that's about the typical size of our family Thanksgivings. So I have dinner with 17 others, and I find out how all the kids are doing and who's going to college and who's not, and all those kind of things. And we watch the game and whatever. And then on Friday or Saturday, I start to develop symptoms. I go in and get tested, and I'm positive. Ugh. So now it's Friday, and I'm feeling gross. Saturday, I get positive. I was contagious on Thursday. And now those 17 people I exposed on day 5. Now, if I exposed them and was contagious, I may not have given it to anybody else, because a lot of people don't give it to anybody else, but some people give it to almost everyone in the room. So I could have given it to 8 or 9 people in the room, and then those 8 or 9 people have it. Now imagine if this is writ large, done many, many times across, we could have so many cases. So even in this case, where I still was in the legal limit for gatherings with my poker party, and I felt well and got a negative test and felt well when I was in Thanksgiving, I could still really have infected others. So the only foolproof thing would be on those 17 family members to have dinner with my wife. Yes, I may expose her, but not others. Dinner with my wife, Zoom with the kids, and then we won't spread this to others. And what I worry about is when I go to this family thing, Sometimes I'm not. Sometimes I'm the oldest guy there, but sometimes there are older, sicker people there who you really want to see, and the kids sit on grandma's lap and all those kind of things, and that's what we don't want to have happen. So, we have this little graphic, and if you could put that up, it would be great. It says the virus doesn't take a holiday. Please celebrate safely. The goal is to get us through this. November, December, January are going to be really, really grim. I mean, I'm not sugarcoating it. It's going to be pretty grim. We're going to have a lot of cases. We're going to have a lot of hospitalizations. We might have a lot of deaths. If we can tamp it down, so we have not quite so many cases, not quite so many hospitalizations, and not quite so many deaths, come January, when we start getting more and more people immunized, especially if in January we can get everybody in the nursing homes immunized. So we're starting to have fewer and fewer of the really severe cases in the nursing homes. We can get the nursing home workers and the other healthcare workers immunized, so we can start moving through that. And then we can do our high-risk people. We can get to a point where by May or June, we're back to a couple of cases, a couple of hospitalizations, an occasional death. That will really be the time to celebrate. So what I'm asking people is not to celebrate, but just not to celebrate in big groups, and to delay our gratification so that in May and June we can really have a big celebration that COVID is mostly behind us. Now, it's not going to be totally behind us for a long time, but it can be certainly mostly behind us by the springtime if we do everything right. On the other hand, if we start having so much disease now, that the disease is so widely spread, what's going to happen is that the hospital systems are going to get overloaded. So I was on a call this morning, and the ICUs in Portland were down to 4 open beds. That is way cutting it too close. Imagine what happens now if we get to a point where we exhaust hospital beds in Portland, and now we're lining people up in stadiums and whatever else. That is so, so awful. And it won't get us to control the disease any earlier, because if the disease is really strong, you're not going to be able to do the vaccinations in January and February. I mean, there won't be enough people around to go ahead and do the vaccinations, and you really won't do it. So I'm just praying with people to go ahead and really be cautious about their exposures, especially this next week. So a little early next Tuesday, but by next Thursday and Friday, we'll have a sense of how successful we were with this message. All right, so a couple of things. Friday, we're going to do Facebook Live again, Friday at 4. I don't know when the Ducks game is. Hopefully it's on at 4 o'clock, because I'm sure I would not compete well with them. But we're going to do this Friday at 4. Again, if you have questions, put them at Facebook questions at douglaspublichealthnetwork.org. Again, we have a crisp $50 bill for somebody who can show us a COVID death in Oregon that really wasn't a COVID death. And I'm just pleading with people to be safe, be kind to each other. We've had some incredible acts of kindness this week, which have been great. We've had some ugliness too, but we've had incredible acts of kindness this weekend. So be safe and be kind, and we'll see you again on Friday. Thanks again. This is Dr. Bob Dannenhoffer. Bye-bye.